Hi, my name is Miranda Erskine, and this is a review of the Not on Tobacco program, a smoking cessation program for teens. Not on Tobacco is a voluntary smoking cessation program for teens ages 14 to 19. It was developed by the Centers for Disease Control and Prevention and the American Lung Association. NOT is an evidence-based program. It utilizes a cognitive behavioral approach which is recommended for helping youth quit smoking. All of these topics are presented with age-appropriate content and language. NOT is recognized by the National Registry of Effective Programs as an effective science-based program. Why is NOT important? According to the CDC, cigarette smoking is the leading actual cause of death in the United States. Smoking has several fatal health outcomes. These include lung cancer, cardiovascular disease, chronic lung disease, and low birth weight, just to name a few. The CDC considers lung cancer as an epidemic and the leading cause of cancer deaths amongst both men and women. If we look at teen smoking specifically, the CDC reports that nearly 9 out of 10 cigarette smokers first tried smoking at age 18 and 99% first tried smoking by age 26. There is evidence that youth may be more sensitive to nicotine and that teens can feel dependent on nicotine sooner than adults. Without intervention, the CDC predicts that teens will continue smoking into adulthood. Youth risk behavior surveys have shown that approximately 56% of high school smokers attempt to quit smoking on their own. However, a majority of these attempts are unsuccessful. This is an indication that tobacco cessation programs for youth should be prioritized as an effective approach to reducing smoking and its health-related risk in the general population. NOT has been recognized as effective in reducing teen smoking. The goal of NOT is to reduce smoking by helping participants quit smoking, reduce the number of cigarettes smoked by those teens unable to quit, and increase healthy behaviors. The target population of NOT are 14 to 19-year-old daily smokers who report smoking on average 1 to 5 cigarettes a day. Participants volunteer to take part in the program. Despite effectiveness of NOT, the program reaches approximately 1% of its target population. A key question we will explore is what efforts are needed to improve reach and increase implementation. The NOT program consists of 10 50-minute small group sessions. The sessions are led by trained facilitators in school settings during school hours or in a community setting. They are gender specific, so the boys are separated from the girls. The teens receive training in several topics such as self-motivation, stress management, the effects of smoking, preparing to quit, dealing with nicotine withdrawal symptoms, relapse prevention. They also learn social skills. All of these topics are presented with age-appropriate language. Participants also have the option to take an additional 4 sessions known as booster sessions after the conclusion of the program. The ALA has adopted the NOT program as a national best practice model. The program has also been deemed a cost-effective option for school-based smoking cessation programs. There are several risk and protective factors developmentally relevant to adolescents, all of which impact the effectiveness of the NOT program. These include the social and physical environment, biological factors, personal perceptions, and other influences. Let's first look at the social and physical environments they belong to. Exposure to tobacco ads may normalize smoking and promote smoking amongst young people. Teenagers tend to be less worried about their health in the distant future than they are with their image and social status among their peers. Youth are more likely to use tobacco if they see that tobacco use is acceptable or normal among their peers. For example, studies of the NOT program show that participants observe smoking more often among friends than parents or siblings. Peer influences can differ between gender. Tobacco companies exploit these. For example, in the 1960s, when tobacco companies started running Virginia Slim ads suggesting that smoking helps with weight loss, the proportion of 14 to 19-year-old girls who started smoking nearly doubled. The KNOT program, which is based on a social cognitive theory, capitalizes on the importance of peer influence by promoting positive peer group interactions and social experiences through team building activities and peer support. Community activism and volunteerism is also a big part of the program. KNOT employs a gender-specific small group session which are facilitated by same group facilitators to address varying gender-based perspectives, and this has been shown to be effective for both males and females. Parental influences is also a key part of KNOT. The program fosters parent-child conversations. This is important because research has shown that parents may exert a positive influence by disproving smoking or discussing health matters with their children. There are several biological factors. As mentioned before, youth may be more sensitive to nicotine and they can become more dependent on nicotine sooner than adults. They experience relapse and withdrawal symptoms similar to those reported by adults. And combating these symptoms may be especially challenging for them and could affect how well they progress through the program. Personal perceptions are also a key determinant. Expectations of positive outcomes from smoking, such as coping with stress and controlling weight, are related to youth tobacco use. Teenagers tend to overestimate the number of young people and adults who smoke. Those with the highest overestimates are more likely to become smokers than those with more accurate perceptions. There are other influences as well, such as lower socioeconomic status, including lower income or education, accessibility, availability, and the price of tobacco products, as well as other things such as low self-image or self-esteem. As a public health program, KNOT utilizes a collaborative approach involving many sectors of the community. On this slide, I am going to introduce you to key players in the development of KNOT and discuss how the program was funded as well as some external stakeholders. KNOT developers include the Centers for Disease Control and Prevention. The CDC is the foremost assessment and epidemiologic agency of the United States Department of Health and Human Services, which is a federal agency. The primary function of the CDC is to control and prevent human disease. One of the main ways the CDC accomplishes this function is through funding epidemiological research through designated academic research centers. These are known as prevention research centers. The American Lung Association, or the ALA, is considered the leading non-governmental organization working to improve lung health and prevent lung disease. One of their main areas of focus is eliminating tobacco use and tobacco-related diseases. Amidst the research about dangers of teen smoking, the ALA developed the KNOT program in partnership with other key players. The primary role of the ALA is in the dissemination of the KNOT program. The ALA produces, packages, trains, and disseminates the program to participants. West Virginia University Centers for Public Health Research and Training is a PRC that is funded by the Centers for Disease Control and Prevention. They developed the KNOT program in collaboration with the ALA and provide scientific oversight, technical assistance, data management, as well as evaluation. They also take the lead role on all reporting and publications. The funding sources for KNOT can vary by region. The primary funding sources include research funding. This is through the CDC, as well as those research centers. Also, there's funding from private donors who donate to the university or directly to the initiative. State and local government can support KNOT through state budget appropriations or through the use of the Master Settlement Agreement. The Master Settlement Agreement is a settlement in which the tobacco industry agreed to pay monies over a period of 25 years to the state in order to compensate for treating smoking-related illnesses. This money can be used for anti-smoking programs like KNOT. Tobacco taxes and revenues generated from increased taxes on tobacco products is also another way that the state and local government can fund a program like KNOT. External stakeholders are those individuals or groups of people with a shared interest in the program or the resulting effect of the program. For example, many of the stakeholders in NOT have a shared mission of reducing tobacco use. These stakeholder includes those who are served or affected by the program, such as the program participants. They get involved because they want to quit smoking. School and community centers often get involved as the primary delivery site for the NOT program. Peer groups and family are also key players in that the NOT foster positive peer group interactions and social experiences, and also fosters parent-child conversations about smoking and healthy behaviors. Those involved in the program operations are also external stakeholders. These include program facilitators. These are your teachers, school nurses, counselors, or volunteer staff. They are trained by the American Lung Association and are responsible for administering the NOT curriculum to participants. Individuals may get involved for different reasons, ranging from career development to volunteering. Legislatures and other decision makers play a key role in the policy development and developing legislation, implementing regulations, which may also impact the NOT program. Some factors of political and ethical concerns are recruitment methods and active parental consent. Recruitment methods must be consistent with community-based participatory research principles. One of such principles is active parental consent. In order to protect minors, the NOT program must require written parental permission before a child can participate in the program in a research context. Some parents may not want their children to be research participants. In a review of recruitment barriers and success of the program, researchers found that students did not want to tell their parents that they smoked. Thus, these students did not want to participate in the program. In my research and evaluation, I did not come across opposition to the NOT program. Overall, the program has been well received by many communities. The program design, delivery, and effectiveness has been supported by research and has been implemented at schools in at least 48 states. While there has not been any public opposition to the NOT program specifically, the tobacco industry may be generally opposed to smoking cessation programs because of the negative impact on sales and profits. There are social and economic and political factors that contribute to the need for the NOT program. These factors also affect the way in which the program is developed and marketed. These factors are social and the physical environment, economic and politics, biological factors, as well as personal perceptions. As a result of these, the program was developed and marketed to include consideration for age and developmental stage, socioeconomic status and educational level, gender, patterns of tobacco use, as well as the commitment to cessation. The delivery and scalability of the program is dependent on community buy-in. It is important to build a marketing strategy in accordance with the community's goals, assess the community's needs and resources, meet with stakeholders, and also be partners in planning. This is important because research of NOT has shown that effectiveness data show variations across regions. One study demonstrated that program funding may influence the effectiveness data. A comparison was done between West Virginia and North Carolina teens who participated in NOT. The study showed that the quit rates in West Virginia was about double that in North Carolina. Researchers speculated that an additional $5.8 million in funds from a master settlement agreement in West Virginia may have contributed to the higher participation and quit rate. There were also discrepancies between the number of ALA-trained facilitators and those actively offering the program. A key area of collaboration will be focusing on increasing facilitator training and overall offerings of the program. I would also focus on the financial benefits of the community. Smoking causes millions of dollars every year in forms of healthcare expenditures, productivity loss, and premature deaths. For every dollar the U.S. state spends on tobacco cessation treatments, there is an average potential return on investment of $1.26. NOT is a successful evidence-based program for teen smoking cessation, primarily because of its assessment, program delivery methods, and evaluation.